A lot of doctors think, well, of course, bariatric surgery of any kind, the way that it works is just restricting how much food people can eat. What would you say to that?
That's wrong. It's not just the restriction, it's also and I hate to use this term because it's so negative sounding, but there is some evidence of malabsorption as well. You have the metabolic changes, you have some degree of malabsorption, and you have restriction. So it's a combination of all those things that cause the weight loss, but also that cause these changes in the patient's comorbidities. But it also decreases your gut permeability, they've noticed. It increases your production of toxic metabolites. So, this is still being studied. We can't say exactly, but they have noticed, that patients whose gut microbiome were, say, harvested from someone who had gastric bypass, and then if that fecal transplant was imported into someone who, or usually a rat, which are the studies that have been done, if that were transplanted into a non-surgical patient, they did see changes. They did see effects, not the dramatic weight loss that you see with surgery, but some degree of change. So there is that component that definitely impacts the success of these patients.
All right, so in today's show, we're going to talk all about the gut hormones, the so-called incretin hormones. Now, I'm not necessarily a fan, and I'm not promoting bariatric surgery or bypass surgery. I want you to understand and listen to this podcast with an open mind. I know a lot of you are quick to making sometimes emotional decisions. We see a video that doesn't agree with our values, and we want to reply or hit the dislike button. But I want you to understand and realize that we can admire the pharmacology, that is how interventional, surgical procedure, gastric bypass, bariatric surgery, and the different procedures that Dr. Kandace is going to talk about. We can admire the pharmacology and realize that there's natural ways to improve those hormone levels as well. And so if you want to learn a little bit more about it, just a small plug, the book that I wrote in 2014, Belly Fat Effect, talks a lot about this. This was the basic premise of the book, that we can augment our gastrointestinal hormones that operate upstream of, say, insulin and glucagon and things along those lines. So the incretin hormones are malleable. They're very important in the context of body composition, appetite, satiety, and fat loss. But again, we're not necessarily always promoting bariatric surgery or gastric bypass. Obviously, lifestyle change can be very effective, but for some people, lifestyle change is not enough. And that's where Dr. Kandace speaks to her career path and some of the changes that she's seen associated with gastric bypass and bariatric surgery. So just wanted to throw that out there as an idea. Hopefully you can listen to this with an open mind, and as you're listening and understanding these mechanisms through which the incretin axis, that is the gut hormones, how they affect our metabolism, and think about the different things like fasting, exercise, the types of foods that you eat, the rate at which you eat and chew, the physiologic state that you're in when you're eating, if you're calm, or if you're wired and stressed out, that will affect your incretin hormones. So it's a really fun conversation. We recorded this in West Hollywood, Florida. Dr. Kandace is awesome. Definitely follow her over on Instagram. Links are below. Her handle is Instagram @slimmingsurgeon. And by the way, hats off to Dr. Kandace, because she was only 6 weeks postpartum after giving this talk. She had just had her baby boy and her brain was on, man. She is a super smart woman, very nice as well. So I hope you enjoyed the content. Let's cut back to it with Dr. Kandace.
Hey friends, welcome back to another video. Very excited to have Dr. Kandace Kichler on. She's a general surgeon and you do a lot of work with gastric bypass. And we've talked about this on the show, Dr. Kandace, about what I think is exciting about the procedure is the mechanisms. We were just talking offline how a full-blown insulin-dependent type 2 diabetic, 12 hours after, I can't remember what form of the procedure, we'll talk about it, Roux-en-Y, there's others, but these individuals no longer need insulin.
Correct.
And that to me was like, so that's what got me into this deep dive of studying the mechanisms. And you're a surgeon, so we're going to pick your brain here, but
sure.
You were kind of talking before we got started here about how you got into general surgery, which I think is pretty exciting. You want to kind of share that?
So I basically, through my medical school training, I became interested in surgery. And in surgery, there are different fields that you can go into. You can go into, breast surgery. You can go into skin surgery. You can go into plastics, special colorectal surgery. But I worked with a mentor who was a bariatric and general surgeon, and really spending that month delving into bariatrics, I became so interested, and I just felt like the changes in these people's lives really just hit home with me, and it became my passion. It became something that I was interested in and wanted to learn more about. So through my residency and then eventually through my fellowship, it's just became what I do and it's what I love. So
awesome. What were you surprised at, like how quickly people get results?
Absolutely. So, people will have surgery and the weight will come off. The weight will come off within the first year to year and a half. But the other changes are what are so dramatic and so impressive. You see diabetes reversal, very, very quickly. You see changes in their cardiovascular health quickly. You see sleep apnea resolve. There are so many different effects besides just the weight, which is why I don't like to refer to it necessarily as weight loss surgery, because it's more of a metabolic surgery. And that I think is amazing.
So some of those benefits no longer have sleep apnea, sleep disordered breathing, diabetes and all that. Does that precede the weight loss? Like what's the chicken or the egg?
It can. So each comorbidity, it's different. So some of them, like for example, fatty liver disease, some of that is directly related to the weight loss. So I can't say that, next week if we do a liver biopsy, it's not going to be fatty any longer. Yeah. Once you reach your plateau of weight loss, then you would see those changes in that case. Other examples like the diabetes, like the sleep apnea, you see the results before the weight comes off. So there are other mechanisms besides just the calorie restriction and the eventual weight loss that cause these changes in the patient.
Good point. In the fitness space, there's like kind of two schools of thought, right? Two camps. People are talking about hormones, like intermittent fasting changes your hormones. It's not just the calorie deficit through fasting that causes fat loss. And other people are like, no, the only way that you lose weight is if you're in a caloric deficit. But you're seeing like some of these changes and stuff like that hormonally, and then benefits. If you were to like 20 years down the road, pick the future, like is it a hormone issue, is it a metabolic issue, or is it a calorie deficit that causes weight loss?
I really do believe that it's a combination. I think that it's not one or the other. Definitely calorie restriction is helping in some of these cases. It is, changing, the patient's fasting blood glucose, and it's changing, their overall physiological condition at that moment. But we also know from multiple studies that there are hormone changes that are happening that if you were to say give the patient a IV glucose load, the patient who had just had surgery versus another patient who hadn't, you see hormone differences and you see different responses to those loads. So it's a combination of things. At least that's what I think. Will we know the answer eventually? Yes, probably. But right now it's still, we think it's this, and we know that these are the results, which are so far excellent.
Yeah. You personally, so you just 6 weeks ago had a baby. Congratulations.
Yes.
What sort of diet, we're going to get into all these mechanisms of bariatric surgery and all that, but what do you adhere to? Like keto's hot right now, intermittent fasting, what do you personally do?
I try to do keto, but when I was breastfeeding, I noticed that I needed carbs to help with my milk production. And I needed energy. So I felt like if I was very strict with keto, I wasn't really feeling as great. And I think that's just because of the physiological and hormonal changes of pregnancy. Aside from that, I like to adhere to keto as best I can. Of course, I'm not perfect. So, but I do believe in that. And my husband follows that diet pretty strictly. I actually have a younger brother who suffers from obesity. And recently he went on a ketogenic diet. And he has lost 95 pounds in the past 4 months following that diet. So, I believe in that. I believe that diet and exercise are the foundation for everything that you need. But there are people who are unsuccessful with diet and exercise. And that's where I think surgery plays a role.
Yeah, so who would be a good candidate? Is it the person that's tried all these different diets or has medical issues that if they don't lose the weight, if whatever, that there's complications down the line that are more serious? Like how do you decision diamond that?
Right, so there's different ways to think about this. Absolutely, it's someone who has medical problems that if they don't get these under control, they're gonna have a significant consequence, like a heart attack, like a stroke, any complication from diabetes. Those people definitely should be considered if they fall into the category of severe or, morbid obesity, if they have that disease, which obesity itself is a disease. You look at it like, oh, I've got diabetes, but obesity is another disease. And that's a big stigma that we have in society today. But so those patients who have the problems that they're gonna, experience some kind of complication within the short term, bariatric surgery should definitely be considered. And it's something that you talk with them, you talk with their primary care doctor, and everybody's on the same page. Otherwise, someone who just suffers from obesity, it's definitely an option, but you have to have the foundation of diet and exercise, because if you don't follow these things after the operation, you can, regain weight in the long term. It is not 100% guarantee that you're going to lose X amount of weight and keep it off forever. So there's different schools of thought, and then of course we have to deal with insurance companies. So there are different rules that we follow for that. You have to have a certain BMI to qualify for the operation if you're going to have insurance cover the procedure. And then if you fall in a certain range, you have to have that BMI plus the medical problems. And that range starts around 35 BMI.
So you have to be obese.
You have
Can't
to
just be a little overweight.
Exactly. You have to be considered severely obese or obese with a medical problem. And there's different, categories for that today.
If someone was going to pay cash out of pocket, what would it be roughly?
It depends on the hospital fees, the anesthesia fees, and the surgeon fees. But, you can go to some doc in the boxes and you can get a sleeve for around $10,000. If you go to a more respected institution that has a program where you're going to see a nutritionist and a psychologist and have a physical therapist follow you around your operation, it could be more on the lines of $20,000 to $30,000.
Do you know what insurance would pay for it? I mean,
insurance will cover the majority of the operation. There are some patients who will pay, a percentage, and I think that ends up being in the ranges of $1,000 or so. It really depends, but
Sure.
It is covered by Medicare and Medicaid in the state of Florida. So we have a lot of people who, benefit from that.
Yeah, super interesting. I'm glad, before you got into it, you were saying that patients really need to make sure that after the fact that they're exercising, changing the diet. What would happen to someone if, let's say, they experienced some initial results and then they said, you know what, I think I'm good, I can go back to eating junk food, I don't need to exercise, and they regain the weight. And then they have the surgery, but is there any hope for them at that point? Have you seen that?
There is. So, unfortunately, a lot of the people that follow up in the long term are the people that haven't had success. The people that have success continue on their life. They don't come to the doctor when it's been 5 years since their operation.
Sure.
But I do occasionally see the patient who had surgery 5-10 years ago, and they completely went off track, went back to old habits, and now they've regained some, or even some of them have regained all of their weight back, which is, very unfortunate. Not common, definitely not the majority. But those patients, step one is to get them back on a regimen, get them back onto a healthy eating diet. Some of them I recommend keto, and then also starting to exercise, because at this point they've likely become sedentary because their knee pain has returned, their back pain has returned with the addition of the weight back on their body. So starting with the basics is number one. There are some medications today that if they don't progress with the diet and exercise, they want to lose a little bit more weight, there are some prescriptions which have limited success that we can try. And then depending on what operation they have, if there is a certain complication with their initial operation, or if they have, for example, they were diabetic, the diabetes has returned, and they had a sleeve, we can convert them to a different operation, to the Roux-en-Y. But that is in very rare select cases, because I don't believe that, if you've had an operation, you should just have another one to get the results you want.
I love that, looking at the root cause. Have you taken any functional medicine courses, or is this just naturally like in your head?
No, this is just my passion.
That's so cool. Yeah, you think like a functional medicine practitioner that really wants to get at the root cause and so forth. That's awesome. Are you surprised when you go in? So some of the research on, let's say, the origin of obesity and the loss of the so-called incretin effect, and how the hormones from the intestine affect pancreatic release and all that. There's fat infiltration around the liver. Are you surprised when you see the organs? Do they look as?
Oh yeah, they look fatty. They look fatty when we go in to operate, and and not just the liver, which has a congested, more pinkish appearance than a normal liver, which is smaller, darker in color. It may even have signs of early cirrhosis if they've had fatty liver for a certain period of time. The omental fat, which kind of drapes our organs, is significantly larger in the patients that we operate on. And then mesenteric fat, which is also, surrounding the intestines, it's, engorged. You can even see some lymph nodes swollen just from the process of the obesity and the different mechanisms that go on. So yes, we definitely see that when we operate. And then if you have the opportunity, or you unfortunately have to re-operate on these patients for something else down the road, you see the changes. You see someone who has this problem, they have, a sleeve or a gastric bypass, and then say, maybe their diet has been off and they now need their gallbladder taken out a couple years down the road, but they've maintained the weight loss. You go in and it's like a totally different body. It looks dramatically different. One of the things that I do preoperatively on patients for 2 weeks is I put them on a very low calorie, almost liquid diet to help shrink that liver and to help shrink the omental and mesenteric fat. And that has been shown to decrease the size and to kind of help with the fatty liver temporarily, so that when I operate, it's a little safer. The liver's smaller, so I can get to where I need to go to do my operation. So
Because if it's really enlarged with fat,
we have to push it out of the way. You can get, the instruments that we use, they're more likely to cause an injury if the liver is extra heavy and fatty. Different things like that we take into consideration, that we've seen improvements with this type of diet before surgery.
That's so cool. Yeah. On another note, I don't want to totally shift gears, but how many women are in surgery? It seems like it's mostly like a male-dominant thing, right?
Yeah, definitely. The percentage is increasing. The number of women applying to surgery right now is nearing 40 to 50%, but those actually practicing, I would say it's probably still 70 to 80% is male. So it makes it interesting when you interact with patients, because some people, have the notion that they still prefer a male surgeon, whereas others are very happy to see a female walk into the room. And, everybody's opinion is different, but as a female myself, I feel like my OCD skills are way more than some of the males that I work with, and so I think my attention to detail is something that helps, and whether that be a female trait or not, I think it is often seen in females. So.
Totally. On a totally unrelated note, but it has to do with this, have you ever flown into Midway Airport on Southwest? It's a very short runway, and normally the plane just hit the deck, slam on the brakes.
Heard of it.
So one time, I used to fly to Chicago every other week for years, and one time we flew in and it was just this delicate, and it was like really smooth. I was like, that has to be a female pilot. And when I was walking out, I poked my head in. Sure enough, it was a female pilot. So so men are just kind of like, let's get it done. It's abrasive. So you're taking that time to tell people to fast and do a liquid diet for 2 weeks.
Yes.
Whereas men might just be like, let's rip it out, not in that manner, but a little bit more aggressive.
Absolutely. I feel like, and I don't want to be sexist, but I feel like women do tend to take a little bit more time with patients, trying to understand what's going on before they jump to a decision. Whether or not, a male and a female may end up at the same exact decision, but how we get there is different, I think. And
absolutely. That's
one of the benefits of having more females in surgery.
Yeah. All right. So you're in the middle of surgery. What procedure? You said Rowan-Y. We talked about, you kind of alluded to the band, gastric band. What's your go-to? And then how do you figure out which type of procedure is good for that patient?
So we determine all this beforehand. The patients that are going to go through bariatric surgery have extensive workup. This is not something that we, see them one time and we book them for surgery. I'm going to see them several times. They're going to see our nutritionist, they're going to see our psychologist, etc. So this is determined before I get into the operating room, but different things lean me one way or the other to which operation I think a patient should have. As we spoke about before we started filming, the lap band is fallen out of favor. It was a kind of a hot item that people could go get done in a little outpatient surgery center and hope that they would lose the weight. But it has, over time, it has proven to be not as effective. You only lose about 30 to 40% of your excess weight. And it has complications. So it can slip, it can erode, it can get infected. People can have problems with acid reflux after the band placement. And so 40 to 50% of people end up needing it taken out, needing it revised, needing another operation because they found a way to eat around the band and didn't lose enough weight. So that one's not necessarily recommended. Most patients today, in my office at least, are going to be offered or counseled the option of either a sleeve gastrectomy or a Roux-en-Y gastric bypass. And, you know, I do believe that the sleeve is a great operation. It's simpler. It's not altering the intestinal anatomy. And it does have effects. It has similar effects with the estimated weight loss. It also has similar effects on the incretins. So you do get those metabolic benefits of the gastric bypass. Not quite as much as the gastric bypass, but you still see excellent benefits. So someone who is suffering from obesity and has 1 to 2 or maybe no additional comorbidities because they're younger, those would be typically good candidates for sleeve gastrectomy. Gastric bypass today, I reserve for someone who is a diabetic, has been a diabetic for several years, someone who has significant cardiovascular disease, but what can withstand the operation. Of course, we make sure this is safe before we do it, and someone who has a higher BMI, so if they need to lose a little bit more weight. In general, the bypass is better for weight loss, better for diabetes than the sleeve, but both are very effective operations that, you know, I offer the patients today.
And where's the sleeve going?
So the sleeve, a lot of people, you know, have this belief that we put a sleeve around the stomach, but what we're actually doing is we're stomach stapling. So we are removing a portion of the stomach. So we take your stomach that you have now and we divide it to a smaller banana-shaped stomach. So what you're eating into has a smaller capacity, and the things that you eat are going to empty quicker. So that's how we believe it has the similar metabolic effects of the gastric bypass, because you have more rapid emptying of your new, smaller, slimmer stomach. So that's the way the sleeve is. So we don't change the intestines at all. We don't reroute things like we do with the gastric bypass, but instead we're just stapling the stomach. It is not reversible though, and some people think, you know, I'll get the sleeve, and if I don't like it, I'll get it, you know, undone. You cannot reverse it. Once we remove that part of the stomach, it's gone.
Interesting. So is Roux-en-Y, is that considered gastric bypass? Because you're
Yeah.
manipulating the, and
Exactly.
so the way that works is, talk about that. So what are you changing? You're cutting out the upper portion of the small intestine?
So basically the Roux-en-Y or the gastric bypass, we take your stomach and we divide it, you know, just as we divide for the sleeve gastrectomy, but we divide it in a different area and we make a small pouch out of your stomach. So it would be about the size of, you know, a very large hard-boiled egg. That's how big your new stomach that you're going to eat into is. The remainder of your stomach is left in your body, but it's just kind of like sitting on the sidelines. It's there, but it's not functioning because food is not coming into contact with it. Then what we do is we take some of your small intestine and we reroute it. So we create basically a Y configuration, hence the name Roux-en-Y, and we connect your small stomach pouch to your ileum. And so your jejunum. So you eat esophagus, stomach pouch to jejunum. And it's that restriction of food into the small pouch and that rapid emptying into the hindgut through the jejunum that causes the metabolic changes that we see.
So the receptors are like, wow, there's food here. Let's amplify the post-meal messages.
Exactly.
And then blood sugar is improved and all that.
Exactly.
But can food go back? So the duodenum and jejunum.
Yes, so you're still going to have that connection. So things from your stomach, which very little is going to secrete from that once you've had the bypass. Things from your stomach, duodenum, pancreas, those are going to filter down and meet with the things that you've eaten, but down the road. So basically you get the things, you know, the different hormones and the different enzymes that affect, you know, fat metabolism and things. You get them, but not until later. So that's why, you know, if a person were to say eat a very, very fatty diet, like a ketogenic diet after gastric bypass, they may experience some diarrhea because those enzymes to digest and break down that fat don't interact with the food until later. So it has less time to absorb the same way that you and I would eat.
Very interesting. Okay, that's pretty fascinating to think about what's going on. So, I mean, everyone's anatomy seems to be slightly different, but when you go in, I mean, you can just see, okay, here's what we're going to do when you start operating. Like, that is so crazy.
Yeah. I mean, you know, you do it several hundred times and if you see something that's a little off, you may have to take a step back or refocus. Like, for example, yesterday, my partner and I operated on a patient who had had a previous C-section, but she had an up and down scar instead of the traditional low fan and steel bikini line scar. So she had a lot of scar tissue. Normally we start operating on the stomach for the gastric bypass, but in this case we started operating on the small intestine because we wanted to make sure that we were going to be able to complete the operation and do the right operation for her. For example, if we would have gotten in there and that small intestine would have been so scarred down from her previous surgery that we couldn't do the gastric bypass, then we may have offered her the sleeve instead. So it's a lot of decision making at the time too.
And what did you end up doing? Sorry.
We did the gastric bypass.
You did? Okay,
yeah,
gotcha.
Yeah, we were able to navigate around the scar tissue.
Because there's scar tissue in the small intestine, or just like the
basically
fascia?
On the abdominal wall,
yeah.
But it can impact the small intestine. Everybody's different. You know, some people scar horrendously where they can't even have surgery after they've had one operation. Other people, it barely, you know, you can barely tell. So
interesting. And that's who you followed up with this morning before you came?
Yeah.
That's so cool.
Yeah. And they're doing well.
Yeah. You know, again, kind of a side note, but I'm thinking about it right now, so I think it's important for people to understand. There's some research on the abscesses, or not abscesses, the adhesions, GI adhesions.
Yeah.
Do you see that, where like these intestinal components are like linked together? How often do you see that?
So typically adhesions are going to be more common after you've had an open operation. So where you've had the traditional large scar where we really, you know, split the muscle, separate the fascia, and get our hands in there. Mm-hmm. The surgery that I do today, 99% of the time, is minimally invasive or laparoscopic or robotic. So it's where I'm using small instruments through small incisions. So the adhesions are much less frequent. You're manipulating, you know, the bowel and the intestine or the stomach just the same way as if you were in an open operation, but it's less contact. So, you know, you're using these millimeter-sized instruments to touch the patient's anatomy versus your actual hands. Mm-hmm. So scar tissue is much less common. But like I said, everybody's different. You have somebody who has, you know, scleroderma or has some kind of inflammatory issue with their body, and they may scar worse even with a minimally invasive surgery. Mm-hmm. So you just really, you know, that's why you get a good history and see what surgery they've had before you operate on someone.
Good point. But do you ever see adhesions before you go in?
Not typically, not if they've never had surgery.
I see.
Yeah.
Yeah, there was a functional medicine practitioner that was talking about that, and he had this theory that a lot of people with constipation or other IBS, it's because some of the small intestine would like adhere, but I don't know what research.
I would say I haven't seen that, but you know, at the same time, I don't think it's outside of the realm of possibility, because say someone who's had Crohn's disease or ulcerative colitis, they have a significant inflammation of their intestines. Those people, you could see adhesions, but we don't operate on those people because they have such intestinal problems. So it's not something I typically run into.
I see. Now, when you do it with you kind of refer to your hands going like this, is that guided through, I mean, is there radiation?
Cameras, videos.
Okay.
No radiation. Basically, we have a camera that looks on the inside. We inflate the abdomen with CO2, which gets absorbed very quickly after the operation versus regular oxygen. And then that camera focuses on the instruments that we use, and we look at a screen.
That's cool.
Yeah.
So do you ever play video games to enhance your ability to live?
You know, I did as a kid, so maybe that had some impact on my skills, but I really loved, you know, Sega and Sonic the Hedgehog and all that stuff when I was growing up. But
that is so funny.
I don't play anymore.
I have a buddy who's a neurosurgeon, and he's really good friends with my little brother, and they're gamers big time. And he, like, at night, that's what he does to like really practice his skills.
No, absolutely. I think it would definitely help.
So funny. I mean, as parents, we're like, don't be on games, don't do that. But they're refining some sort of skill set, whether or not they use it or not later in life.
Your fine motor could definitely improve with that, for sure.
Yeah. So the mechanisms, a lot of doctors think, well, of course, bariatric surgery of any kind, the way that it works is just restricting how much food people can eat. What would you say to that?
That's wrong. You know, it's not just the restriction, it's also and I hate to use this term because it's so negative sounding, but there is some evidence of malabsorption as well. You know, you have the metabolic changes, you have some degree of malabsorption, and you have restriction. So it's a combination of all those things that cause the weight loss, but also that cause these changes in the patient's comorbidities.
And then we talked about the incretins, so the incretin effect. There's some interesting research on the changes in the microbiome.
Yeah.
And is that part of that malabsorption? The bacteria don't have time to maybe like ferment it and create?
That's true. It definitely has some effect on the fermentation, but it also decreases your gut permeability, they've noticed. It increases your production of toxic metabolites. So, this is still being studied. We can't say exactly, but they have noticed, that patients whose gut microbiome was, say, harvested from someone who had gastric bypass, and then if that fecal transplant was imported into someone who, or usually a rat, which are the studies that have been done, if that were transplanted into a non-surgical patient, they did see changes. They did see effects, not the dramatic weight loss that you see with surgery, but some degree of change. So there is that component that definitely impacts the success of these patients.
Interesting. And then there's also like the short chain fatty acid changes and all that in the colon. What side effects outside of like malabsorption and maybe long-term micronutrient deficiencies, what other things you tell people like, hey, maybe is there any cancer risk or other long-term things?
Yeah, so there are different complications or risks that I talk about with every patient. There are direct surgical risks. You can have like bleeding, you can have stricture, you can have injury to other organs, things that just come with having an incision. And then there are the long-term complications. So you can have strictures. Like I said, everyone scars differently. So someone may scar more tightly on the area where we make these connections or do these divisions, and then they may have trouble eating after surgery. It's not common, but it can happen. And specifically the bypass, you can have ulcer formation where that stomach is meeting that small intestine. Our small intestine is not used to being next to the stomach in that close proximity. So depending on how much hydrochloric acid you have left remaining in that stomach pouch, you may develop a small ulcer. Typically that can be treated with medication for a short period of time and it goes away, but that is a long-term risk. Like you said, the malabsorption, and today the degree of malabsorption after gastric bypass is significantly less than what you and I have probably heard, or what you hear on the street, like, oh man, my friend had gastric bypass and now he, looks like he's on his deathbed. He's anemic and gets blood transfusions once a week. That is not the kind of malabsorption that we see anymore because we have changed the way we do this operation. In the past, the roux limb length or the degree of bypass was so great that was a real concern. Today we have shortened that bypass length to where your malabsorption rate is much less. So just taking a daily multivitamin plus a couple B vitamins is typically enough to prevent any kind of long-term complication from malabsorption. And then, with the sleeve, we're still studying the degree of reflux that you can see after that because you're making the sleeve into a small, basically like a tube. And so when you put something in a tube like food, it may back up if it's too tight or if you're overeating. So we can see that in patients as well. But, everybody's different. Large majority of patients don't have a complication. Of course, when you read online, the people that have the complications are the ones that are writing the reviews. So it gets such a negative, reputation, but the benefits are there and it's definitely right for certain people.
You said the Roux length. What does that mean? So
the way we bypass the intestine, we bring up that limb of jejunum. In the past, we would measure it out to be 150, 200 centimeters, even, some people even longer. And they thought, previously, the longer you make that limb, the more they're going to lose weight or the better their operation is going to be. But what we have found is that you can use a standard length, 75 to 100 centimeters, and the patients still get the benefit, but they don't have those risks of all the malabsorption because you're not bypassing it to such a dramatic degree. And, everyone is different in the exact length of their small intestine from the duodenum all the way to the colon. And so by limiting that proximal point, you are ensuring that the amount distal, that where all the absorption and all the metabolic changes are going to happen, is enough that they're not going to have a major complication from nutritional deficiencies down the road.
I see. So you follow the research, or that's a patient by patient basis on like how?
We typically follow the research with that, and In my practice, we do a standard length. We do everybody, somewhere between 75 and 100 centimeters for the root limb length.
And it used to be shorter or longer?
It used to be longer.
Longer,
so
I see.
that the bile acids and pancreatic juices wouldn't mix until way down the road, where they would only have a short period of time to work.
I see.
Yeah.
Super interesting. Do you think in 10, 20, 30 years we'll have a pill that will mimic the pharmacological effect of the surgery?
We've been waiting for that for 10, 20, 30 years, and it hasn't happened. But never say never. I think the complexity of the mechanism that happens after these operations is too great to be put into one single pill. But I think there are different things that can be, focused and harnessed into a medication that may help, but I don't think you're going to get the degree of benefit. I hope that it happens? Absolutely, because I don't think everyone needs to have surgery. I'm not someone who's here to just try to cut everyone, but, for the right person, it's the right thing. If there were a pill, that'd be great.
Mm-hmm. Do you think Metformin offers some of that? I know, because I've heard that Metformin is really poorly absorbed.
Yeah.
And some of the changes that how it affects insulin are through the incretins in the gut. Mm-hmm. Do you study that much? Or?
I don't study Metformin that much, but I would say that the degree of any weight loss or any benefit in the long term that is seen with Metformin is definitely not near as great as surgery. And patients typically don't like to take that medication. They don't feel well taking it. It has different impacts on your kidneys, things like that. And so I would not put someone on that unless they absolutely needed it. Mm-hmm. That's my opinion of my limited knowledge of that.
Sure. Are you okay talking about like the GLP-1 agonists and things like that?
Yeah.
Because I know some of those, these are different drugs and so forth that kind of affect the incretin axis, mm-hmm. which is mediated through the surgery that you do. Some of those, I think, I can't remember if it's DPP-4 inhibitors kind of whip the pancreas more. They're kind of like the old sulfonylureas.
Yes.
Do you recommend those or?
I don't. And like I said, when I talked about what patients who have regained weight, what they can do, mm-hmm. in some of those patients, I think it's good to consider these medications. But in the long term, they haven't been proven to be too effective. They may get a 5 to 10% of their excess weight loss. But once you stop the medications, the weight comes back on. Mm-hmm. And unfortunately, majority of these medications are extremely expensive. So, is there a better way with diet, exercise? Absolutely. And I would hope that that would be the way that we can get success with the patients versus giving these medications. But yeah, like what you're saying, it does help, and you can see some weight loss with these medications, but like I said, you can only take them for a limited degree. There's other side effects. If certain pancreatic or thyroid malignancies run in the patient's family, they're not even a candidate for taking them, different things like that.
Yeah, good thing. I was going to ask about Obesity Week because I know you've been going for a little while and things
mm-hmm.
like that. But one question that I had, and I didn't ask you at the time because I didn't want to interrupt your flow. You were saying that with the sleeve, it kind of turns your stomach into like a banana.
Yeah.
Or one of them was like a hard-boiled egg. For context, how big is the stomach normally?
The stomach normally, I would say it's the size of like a cantaloupe. Like at its most, at its distended. Full state, it would be, about the size of a cantaloupe, a small, ball, I don't know, mm-hmm. like a dodgeball.
Small soccer ball.
Yeah, something like that. But that's, fully distended. When we go in to operate, we suction out the air and everything. And so it's probably, flattened like a whoopee cushion, wow. for example. So
it's teeny.
Yeah, it's not that big.
How bad is overeating? Like when people binge and like oh, I'm so full. Like Thanksgiving was 2 weeks ago or whatever, right? Like knowing what you know about the anatomy and how things go through, seeing all these intestines, how bad is that, do you think?
I think that your body has enough protective mechanisms that, it's not going to kill you. But yeah, it definitely puts some strain on your intestines. You're stretching things out, you're increasing your capacitance. At the same time, your body is going to be sending out all these hormones to slow down certain areas, digest certain areas, and you're putting stress on your body, mm-hmm. which is probably why we feel so tired. We have these big carb loads, and then, all these different changes happen. You feel like crap after you've eaten Thanksgiving or Christmas dinner. Inside, your body is going to take care of itself. Rarely do you see someone who perforates their stomach or their intestine from overeating because we've got these, balancing acts, your stomach stretches, other parts relax in order to accommodate for the food. So
does the stomach stretch over time? Like if Mike Mutzel starts overeating, is his stomach going to turn into a basketball?
It does, but you'd be surprised. We have some patients who obviously are overeaters, and then when we operate on them, their stomach looks just the same size as, you know, yours or mine. So I think everyone's different. But have I seen massively distended, stretched out stomachs? Absolutely.
Super interesting. You mentioned we're not going to get a perforation if we overeat, but there was this procedure. I think it was done in Finland or something like that. It was like a port. So when you overeat,
oh God, don't even get me started on that. I think that's just ridiculous.
Right?
It's basically, you know, like giving yourself bulimia.
Yeah.
Like let's eat whatever we want and then open it up and empty it out. Like that's, you know, when we talk about surgery, we talk about we're operating on your stomach, we're not operating on your brain, but that's just, you know, all wrong.
Was that real or was that a joke?
It's real.
People are doing that.
I thought it was a joke too,
Yeah.
but it's real. Some people do it in the U.S. You know,
Wow.
it's there, but I wouldn't recommend that. I really
Yeah.
wouldn't. It's not helping anything. It's not changing anything metabolically, and it's not, you know, it's not impacting the, you know,
root cause
overall exactly the, you know, psychiatrics behind what's going on.
Do you think a lot of these people that are morbidly obese, is it a food addiction?
I think that there are so many things that play into the disease of obesity. Some people absolutely, other people no. You know, you have to consider genetics, you have to consider the environment, you have to consider the foods that we eat today. You have to, you know, think about things that run in people's families, either these inherited disorders that can cause the disease of obesity. So is food addiction common? Yeah, we do see it all the time, but it's definitely not everyone's case, and you know, it needs to be ruled out before we operate, because you can have problems down the road if you are still having issues with food addiction, but it's not in everybody.
The gender that you operate on, is it more women, men?
It's
is it mixed?
mostly female, and you know, I think a lot of that is just the perception of the operation. I think women are more likely to undergo a surgery to help with their, you know, physique or their appearance versus a male. And that's what a lot of people still consider bariatric or metabolic surgery. They still consider it something just cosmetic, whereas it has such great impacts on your comorbidities. If the general public knew that, I think there would be a greater percentage of males undergoing the operation.
Men are like, I can figure it out on my own.
Yeah, absolutely.
I'll get to it.
Absolutely. There's also that willpower aspect. You know, men are like, no, I don't need that. And then, you know, for men, it's a little more acceptable to be larger in today's society.
Such a good point.
You know?
That makes a lot of sense. Let's talk about kids. So you have a 6-week-old, which is
Yes.
so impressive. I can't believe you're doing this right now. I'm very grateful for the opportunity.
Yeah.
That's awesome. And you're really on point and articulate, which is great. So we know that there's this recidivism, like in children that are overweight. As kids, they tend to be overweight as adults. And I know you've talked about that on your Instagram and social media, which, by the way, guys, definitely follow Dr. Kandace. It's Slimming Surgeon.
Slimming Surgeon, yeah.
You share some cool stuff, family stuff, behind the scenes stuff, but then also research and everything like that. How important do you think it is for parents right now and doctors to be aware of that with children? Like it's not just...
Gosh. I think it's like paramount. What you're feeding your kids is definitely going to impact them in the long run. Like, you know, I started breastfeeding and I was trying to maintain a healthy diet while I was doing that to ensure that he gets the proper nutrition. Going back to work, I work between 3 different hospitals, so breastfeeding and pumping, doing that, it was just not something that I was willing to continue to do. So we have transitioned him over to formula at this point, but you know, before doing that, I made sure I researched what kind of formula I'm getting, what I'm putting into his body. If you go to Publix and you just pick up, like, I'm not going to name a brand, but if you just pick up a generic formula and you turn it over, the first ingredient is corn syrup. You know, like that is not healthy for your baby. So, you know, you have to really research these things, but studies have shown that if a child is obese in their toddler years, at age 2, age 3, the chance that they're going to be obese as an adult is extremely high. You know, it's like very rare that they're going to have these habits and this, you know, this metabolism of someone who's obese and it's just going to go away when they get older. It doesn't happen like that. So you have to really think about what you're putting into your kids. I think, you know, organic, I think, you know, natural, limited processed foods, that's the way to go.
Absolutely. Yeah, I try to walk my daughter to school and pick her up as much as I can.
And you have to, of course, let them
get
outside and play. Yeah.
And yeah, part of that to get the circadian rhythms and all that. But I noticed like and maybe it's just my memory's not as good. 36 now, like I don't remember, but I see way more overweight children like at her school compared to what I saw growing up. And not trying to be judgmental or put a stigma on obesity at all, but I do see that this is a major, and the statistics show.
Yeah. I mean, I don't know the exact statistics for children, but if you look at the population in general, in adults, in 1990, the percentage of people who were suffering from obesity was like 5 to 10% in most states. Today, it's like 40, 50, 60% of people are obese and suffering from all of these problems that are associated with obesity. And it's an epidemic. Like it has been declared an epidemic, which is really sad.
Mm-hmm. And like you said, the AMA, or who was it? Not the AMA, another group classified it as a disease, obesity as a disease 3 years ago, right?
Exactly. And then recently the NIH, which, we can talk about, there's a whole nother, we can go on different tangents about these different societies and, people that fund them and things like that, which I don't always agree with. But if you look at the NIH, the AMA, the different overall medical societies, they do consider obesity a disease. They do consider bariatric surgery to be a effective treatment for that disease. But like I said, it has to be in combination with diet, with exercise, with healthy lifestyle changes. It's a tool. It's not a quick fix. And it's something that needs to be maintained.
Yeah, good. That's awesome. So you've been going to Obesity Week for quite a while, I think, a number of years. Any key takeaways or any trends that people should be aware of that are emerging from that conference?
There are some new endoscopic therapies that are coming in the pipeline. I don't think there's enough research to determine if they're going to be long-term effective as actual surgery. There's the balloon that people can implant into the stomach. It doesn't cause metabolic changes. So, the impacts on diabetes and things like that are limited to what happens from losing weight. There's also endoscopic suturing, which, having done endoscopic suturing myself for, different reasons, I can say it's probably not durable in the long term. And, it's something that's to be studied, and I think we just have to follow along with that. But that's some of the stuff that's emerging now. I am not familiar with any new drugs at the moment, but this past Obesity Week was like a week after I had my baby, so I didn't attend this year. Yeah.
I can imagine. It's in New Orleans usually?
Every year it's different. This past year it was in Nashville, which would have been awesome. Previously it has been in New Orleans. I think the next one's in Las Vegas, so that'll be fun.
Yeah, that's more central.
Yeah.
It's hard to get to New Orleans or Nashville for me being in Seattle and stuff like that. But let's finish off a little bit on mindset. Like, can you tell, or what mindset characteristics are, do you see in individuals who have success with the procedure than those who don't?
Absolutely. And unfortunately, there are people who you can tell probably aren't the best candidates, who have had surgery or who are going to get surgery with someone who doesn't pick up on that. Someone who considers it to be, quick fix, or who considers the operation to be something that they have to have, or else they can't just lose the weight. I think you have to consider this, and this is, what I use in my everyday, discussion with the patients. You consider this a tool. It's going to help you. It's something in an adjunct to healthy lifestyle changes. And if you have someone who's not willing to make those changes, or who doesn't believe in making those lifestyle changes, or who doesn't have the means for whatever reason to eat healthy and to exercise after surgery, then those patients tend to fail. And you can see that sometimes before. That's one of the important parts. Every week at my office, we have a multidisciplinary meeting. So it's myself, the other surgeons in our practice, our nursing staff, our psychologist or psychiatrist, our nutritionist. We all meet together and we talk about the cases that are coming up. And if there are any red flags, like, this patient has called me 17 times and they still aren't understanding the diet that they're going to need to follow afterwards, that's somebody that we bring in and we reevaluate, and we talk about whether or not this is really a decision that they should be making. So
I'm just curious, why would that, because that they're how come they're not the right candidate?
it can be, they have some underlying psychological condition. They, unfortunately don't have the mental capacity to understand the different macros and the diets that they're going to need to follow afterwards. Or they may just not have the willpower or want to follow those changes after surgery.
Yeah. So they're already thinking about what they can't eat. And they're like, well, I just want to confirm. Are you sure you're saying can't eat this kind of thing? Okay.
Right. Or they, they'll tell their family members, this is what I see sometimes is that a patient will be like, oh, I can't wait to have my last meal, and they completely binge. That's not the right mindset that you should have before you have an operation like this. So.
That's a great point. My mom just had mitral valve prolapse, which was a pretty invasive procedure and stuff to, I guess, to get the leaflet clipped or something.
Yeah.
I don't know the procedure too well. And so what do you advise for surgical recovery? Like if someone needs to get an electric, did I say that word? Like if they, on their own volition, are getting surgery,
like an elective procedure.
Yeah, what would
Just
they do?
Any procedure in general. I would say, if you have any degree of obesity, I think it's important that you are focusing on a healthy diet before surgery. I think that protein is an important basis and fundamental of your diet that you should adopt or take on before you have an operation, because you want to be at your most maximal nutritional state. You don't want to be in a catabolic state before you go into surgery, because you're already putting stress. And then after the operation or procedure, whatever you need to have done, similar, high protein, getting up that albumin, making sure that you are well hydrated, getting plenty of sleep. These are things that you need to do. Also, there's, I have seen, people who exercise before and after any kind of operation procedure recover so much faster. I mean, I experienced that myself after my delivery. I exercised up until probably 2 to 3 weeks before, and then I got extremely exhausted because I was still working, but I would, still walk around and still operate. I worked out all the way up until, and then my recovery was great. I didn't gain excess amounts of weight with my pregnancy, and then I was able to bounce back and be there for the baby when I needed to.
That's awesome.
I think that can be transferred into any kind of procedure you have.
Totally. I think people are like really scared about doing exercise. Like, oh, I'm going to make it worse. I'm going to like tear the suture or whatever.
And there are limits.
Sure.
Absolutely. And we tell people no heavy lifting. Typically it's like no more than 10 to 15 pounds extra weight after you've had, a procedure where your fascia has been, incised. But that is limited. That's usually 3 to 4 weeks after the procedure. Then you're healed enough to where you can start resuming the normal activity. But walking even is good, getting up, moving around, getting some sunshine, again, making sure you're hydrated and getting the right nutrients. All of those things are really good for you before and especially after any kind of procedure.
That's awesome. You mentioned fascia, and I think it was in 2017. I can't remember if it was the Lancet or some article said that fascia is like an organ system. We know it's like all interconnected. Does fascia excite you?
I wouldn't say it excites me. I think it's super important because it maintains the integrity of your entire body, but it's not something that I've necessarily researched in that level.
Yeah, just curious on that. All right, so let's talk about mindset. We'd like to finish off with just you personally, Dr. Kandace right here. So getting through medical school and then internal medicine, then general surgery residency, that's not an easy feat, especially as a woman. What sort of mindset characteristics, like how you're speaking to someone that is aspiring to be like a medical school student or doing something great, how did you have that grit, the tenacity to just stick with it?
I think that a lot of the reason why I continue to push was basically driven by my family. When I was younger, I saw the successes and the failures of my own parents, and they always pushed me. There would be times where I was like, I don't want to really do the honors program. I think I'm going to quit. And my mom would be like, absolutely not. You need to stick with it. This is something that you've always wanted. And just having someone there, having a support system that encourages you in a positive manner can keep you going. Now, once you get into these rigorous degrees of study, like medical school was insane, residency, the hours, the amount of work you do is insane. I think if you really want something, then the drive is there. And I've always had the want and the determination to get where I wanted to be. it's just, when I see the changes that happen to a patient after they've had surgery, or, they've been treated by a physician in a positive manner, just those changes make me want to be better and continue to do the same thing. I've never looked at it as, I have to do this. It's more like I get to do this because I get to where I want to be at the end. So just having that positive mindset, that continue to get where you want to be, and that drive, I think really is key. And if you don't have that, then maybe it's not the right field for you.
Yeah. We got to explore or pick something else.
Yeah.
So
right.
What drives you is the patient satisfaction and those stories where they say,
yeah.
hey, Dr. Kandace, this changed my life. I'm
yeah.
so grateful for the opportunity to work with you.
Yeah, definitely.
That's awesome.
When you see someone who was severely depressed and, could barely move around and was bedbound because of their disease, and then you perform an operation that takes 2 hours, has a couple weeks total recovery, come back to you after 6 to 12 months and they've lost 150 pounds, they have an entirely new life, they're able to move around, they're able to, exercise and socialize and get out in society, they've changed their dress size by, 2 digits. Those things are what is amazing to me and what drives me, just seeing that happiness and that total change in, mindset of the patients. That's what I really love.
When you have a bad day, like things aren't going the way, patients, things are stacking up, you're charting, dealing with insurance companies, whatever. What carries you through that? Do you think of those success stories or what?
Yeah, I think about those success stories, and I think about how much I've, put into all of this, which is a lot. And, I think the next day it's going to be different. The next day you're going to have a better day. I look forward to the things that are coming up in the future, and that's what kind of drives me through. Everybody's going to deal with those negative things, especially the charting and the insurance companies, that will drive you up the wall. But knowing that at the end of that, if you can filter through that and someone's going to, feel better, someone's going to stop you in the hallway and say, thank you so much. Those are the things that make it worthwhile. Like recently when I was a resident, I helped with a case, like an appendix surgery, which to me is not like a major operation anymore. Like that's, it's frequent and it is major to the person who's having it done, but it's kind of minor. So I helped with a appendectomy when I was a resident, and when I came back as an attending, one of the nurses stopped me and said, you helped me this many years ago. Thank you so much. Like that is crazy because
awesome.
You don't expect to get those thank yous, but when you do it, it really makes a big deal.
Because that can be fatal, right? If someone has the appendix
absolutely.
ruptures and everything like that.
They can develop sepsis, they could, it's rare that happens today, but it definitely can happen. And just, having people say the thank yous and seeing the appreciation, that's what I like to work towards.
That's awesome. A lot of people in your shoes kind of feel like they're called to do this, like best-selling authors. I was with David Perlmutter a few days ago. I was like, I just feel like this calling.
Yeah.
Do you feel like you're doing exactly what this world has wanted you to do?
Definitely, especially with the bariatrics. I don't want to say that I'm like the most skilled person in the world, but I have skills that when compared to others, I think that I've definitely been given a gift, and this is what I'm meant to be doing. So I'm happy for that and grateful for that.
Okay, so you said the procedure was about 2 hours, right?
Yeah, mostly.
Let's see, what's the most procedures you've ever done in a day?
Well, personally, as a private practice attending, I've probably done 3 to 4 surgeries in one day. But during training, I've done many more, maybe 6, maybe 7. Wow. But some of them could have been shorter. Some of them may have been 30 to 45 minutes, and then you go back to back if they're able to let you switch rooms quickly. So it really just depends. But I typically don't operate for more than 5 to 6 hours a day, unless it's a busy call day or we've got a lot of emergencies and things have to get done that day. Because I think fatigue does play into how well your decision making is, and I want the patients to be safe.
Totally.
So.
Let's say you had 5 or 6 procedures on the schedule, right? It's like 2 weeks from now on a Wednesday, whatever. What are you going to do that night and then in the morning before that to make sure that you're on?
Oh, the night before, sleep, which is why I'm glad I have a very supportive husband. With a new baby, sleep is critical and rarely found, but Having someone be there with you to help you so that you can get some sleep is super important. Being well rested. If I need to review some kind of anatomy or certain aspects of the case the night before, I'll do that. But then the morning of, I think it's important to get up early enough to where I'm not feeling rushed or stressed. Eating healthy, definitely being well hydrated, getting in a good amount of protein before I start my day. Because the last thing you want to do is get into an operation and feel weak or feel, tired or stressed, having all these, catecholamines running through your body because you had to take the expressway, and cost you $30, something like that. You don't want negative things to happen before you get there. If they do, you work through them, but trying to avoid that is key.
Mm-hmm. Are you in a flow state when you're performing the procedure?
Yeah, you don't really realize what time is when you're operating. At least I don't, unless I've been in there for 4+ hours. It just kind of, we start, we get it done, and then you look at the time and you're like, oh, okay, sounds about right, you know?
That's because you have to be in the zone, right? Because they're on anesthesia, you gotta
100%.
go.
100%. You have to really just focus on what you're doing.
That's awesome. If you had an idea of like how we could prevent obesity and you were to talk to a politician, you've seen many overweight, obese patients, in your career and stuff like that. What do you think is like the biggest factor? Like if we could make some policy around this, what would you say?
I think the impact of industry and the impact of different financial sectors on our nutritional recommendations in the United States is horrible. And I think that definitely needs to change from the ground up. My father's a farmer, so having a family member who, was pushed or given limited options in the crops that he grew during a certain time due to financial reasons or due to limitations in quantity is just ridiculous. Like, for example, I remember growing up, my dad had to switch to a certain kind of seed because that's all that they carried, and that was the only one that was affordable. So he had to grow a certain kind of crop. And, having these kind of restrictions and these limitations is negative because it has a downhill effect. If my father's growing a certain kind of crop that may be GMO, and then that goes into the food that we eat, and then we all become obese, where are we going to draw the line? We need to start from the beginning, realize that big companies, cannot be influencing what people are growing and how they're growing it, and then everything else kind of from there. Nutritional recommendations are ancient in this country. They need to be revised, those kinds of things.
It's such a great point. Where does your dad live currently?
Alabama.
Where does he grow?
He grows lots of different crops, and every year it changes, but he also has cattle. So sometimes corn, sweet potatoes, soybeans, different things like that. And then he has a cattle farm as well.
Are they like grass-fed and all this sort of
They
stuff?
They are grass-fed and they're, free range, but they do get some grain as well.
Grain finished type of deal?
Yeah.
Did you grow up eating a lot of like what you guys grew?
Totally. Yeah.
That's so cool.
Lots of beef, lots of deer because my family's hunters as well. But yeah, lots of broccoli, sweet potatoes, corn. I ate all that.
But you've seen how industry can influence and kind of tweak the
absolutely.
The farmers. This is all we got, and then once you buy the seed, you got to buy this pesticide because it's patented.
Exactly.
Oh man.
Exactly. Or you can buy this seed, but this one that's GMO is half the price. So you need to grow this one. Those kind of things. It's very unfortunate and negative.
Yeah. So a lot of people blame, we'll kind of blame the farmers. Like, these farmers are just making more money off soy. But it's like they don't understand the politics going on. And
there are a lot of different things that play into that. And, that's a whole nother discussion that we can have. But the majority of the time, if someone is a farmer, they're working really hard. They're not trying to do this to make money, to, become a millionaire. It's what they like to do. Someone who wants to wake up at dawn and go to bed every night at dusk and spend their entire day out in a field, their motivation is not money. So having those negative influences is really unfortunate because it's not likely to be the decision of the farmer.
Right. And then it's not, having seen that, would you ever want to be a farmer later in life? No. No, I'm a stay inside kind of girl. Yeah. As a kid, were you out there and picking
I
up?
was when I had to be. You know, I don't know. I wouldn't say I'm a total diva, but kind of. And so I graded sweet potatoes. I helped pack cotton. I drove out in the field and looked at the cattle. But I'm not really a dirty kind of girl, so not my cup of tea. But.
Right. Interesting. That's so cool. Well, your child, like later in life, you can go learn some practices from your dad.
I already told them I'm sending him to camp.
Yeah, Camp Grandpa, go out on the farm. That is so cool. Well, it's been great connecting with you, Dr. Kandace. And again, you're pretty active on Instagram. Any other, like if folks are listening, they want to reach out to you, maybe they're a patient in Florida.
Yeah, I think mostly the main way to connect with me would be through Instagram, Slimming Surgeon. I do have a Twitter. I'm not as active on there because I like pictures, and Instagram is so much more fun. And they can also connect to me just by Googling. My office can be found there, and you can call, make an appointment. I'd love to see anybody that wants to come in.
That's awesome. Really appreciate the opportunity. Thanks so much for coming on the
thank
show.
you. Thank
And I'll
you.
put all the links below, guys. So really hope you enjoyed this video. Please hit that like button. And I would love to know any comments or questions you have. We'll be following the comment bar as well. And in the show notes, I'll put links to Dr. Kandace Kichler's website and Instagram as well. All right, we'll catch you in the next video. Thanks so much.